Hello and welcome back to ACCRAC. I'm Jed Wolpaw, and we are back with another fantastic keyword episode with the one and only Dr. Tym Kajstura. And we today are going to talk about central and peripheral nervous system anatomy. Super high yield. Lots of questions on this come up on ITEs and board exams all the time. So, Tim, thanks for coming back to tackle this one.
My pleasure as always. And I promise we'll get to the nervous system anatomy, but I have a couple things to take care of at the top. First, I owe a big thank you to Crystal Lang, one of our amazing Hopkins medical students. She helped me comb through the entire ABA content outline and all the ACCRAC episodes to better understand what we've covered well so far and what still needs to be covered on the keyword episode. So thank you again. It was a big effort.
Thanks, Crystal. That's awesome.
And I'd like to make a plug again for any requests for topics or comments about the keyword episode. Send those to ACCRAC@ACCRAC.com.
Please do.
Second, spending some time in the archives gave me an idea to kick off the keyword episodes. We're going to do a little spaced repetition and reinforce some previous concepts. So, Jed, sorry to put you on the spot right from the top of the episodes, but it's time to review some old questions.
I love this. I think this is fabulous. Let's do it.
All right. Number one, a patient with a hyperfunctional benign parathyroid adenoma has undergone a successful parathyroidectomy with no apparent intraoperative complications. Which of the following is standard of care postoperatively for this patient? A, phosphorus infusion for at least 14 hours. B, intermittent monitoring of calcium with repletion as necessary. Or C, intermittent monitoring of potassium with repletion as necessary.
Great. Taking us back to our endocrine episode. And so hopefully folks remember that when we have a parathyroidectomy, or a thyroidectomy for that matter, the concern is that there may be not enough parathyroid hormone left, parathyroid organ left to allow calcium homeostasis, and so calcium can get very low. And so the main thing we want to be thinking about is monitoring calcium, and then, of course, repleting it as necessary. And if you've ever seen someone who is profoundly hypocalcemic after one of these surgeries, it is not hard to miss. They get all the classic signs. They can't open their hands. They get tetanus. It's really, really interesting. So, and then it goes away when you give them the calcium. So definitely the calcium is what we want to monitor.
Absolutely. And you alluded to this. If you take out the thyroid, you may inadvertently take out the parathyroids. It is not a side effect of taking out just thyroid tissue. That is all you get.
Exactly.
Question number two, which of the following qualifies toward the quality improvement portion of the current ABA maintenance of certification guidelines? A, attending a mortality and morbidity conference. B, completing 30 MOCA-minute questions a quarter. Or C, presenting at a mortality and morbidity conference.
Great. So folks who are trainees maybe don't know this that well, though we did go over this. So hopefully you know a little more than you did before you listened to our episode on this. But it's important to know that there are different pieces of the kind of puzzle of what you have to do to maintain your certification, your board certification. One is doing 30 MOCA-minute questions every quarter, but that does not count for the quality improvement portion. That is just the MOCA-minute ongoing learning portion. So for the quality improvement portion, there's a whole list of things that you can do. Each is worth a certain amount of the total that you need. And one of them is presenting at a morbidity and mortality conference. Just attending, though, does not count. So you have to present, and that's the right answer here.
Great. 3, which of the following criteria is not present in both the post-anesthesia discharge scoring system and the Aldrete scoring system? A, blood pressure, B, nausea and vomiting, or C, activity level?
Great. And this is one of those things that I find very tricky because in my mind, and the way I remember it actually is that I think it's the thing that absolutely seems like it should be included, but it's not, which is nausea and vomiting. I think you can also think that blood pressure, like that's really crucial. You obviously shouldn't send someone home if they're going to pass out immediately. Activity level, kind of maybe along those same lines. If they can't get up and walk without getting orthostatic hypotensive, that, is dangerous. Whereas you can go home even if you are nauseous or even vomiting. People vomit at home all the time, right? So that is not pleasant, and ideally we would not do it, but it's something that, I guess that's one way to think about it, that is not prohibitive.
Yeah, you nailed it. It's super strange. It is. It hangs us up in PACU all the time, extends PACU length of stay, but is not part of the discharge scoring system.
Great.
Question 4, and the last one of our review, transfusion with which of the following blood products carries the highest risk of the recipient developing transfusion-related acute lung injury? Is it A, fresh frozen plasma, B, apheresis platelets, or C, prothrombin complex concentrate?
Yeah, and we've gone over this one too. So it's definitely FFP or fresh frozen plasma that carries the highest risk of TRALI. Because it's in the plasma that is the causative agent, and obviously you're going to have more plasma. You can have plasma there is going to be some plasma in other blood products, but obviously fresh frozen plasma is the main one, and so that's the reason.
All right, now let's get to today's topic. This sits in the basic portion of the ABA content outline, and specifically we'll be covering section C. Organ-based basic and clinical sciences. The first one in the list there is the central and peripheral nervous system's anatomy. They want us to cover one, the brain, including the cerebral cortex, and within that, the cerebellum, brainstem, and a couple of other topics. Two, the spinal cord and spine, with a few subcategories that we'll hit. Three, the meninges. Four, the parasympathetic nervous system. And then five, the sympathetic nervous system. And they give us a few subsets that they really want us to hone in on. So that's what we'll get to today. And as always, we can't be comprehensive here. We'll focus on the subset of these things that seem to get tested the most. It will not be a comprehensive review. Starting from the top with the brain, for our purposes, we're going to divide it into three main parts: the forebrain, the brainstem, and the hindbrain. The forebrain will split into the cerebrum and the thalamus, the brainstem into the midbrain, pons, and medulla, and the major portion of the hindbrain is the cerebellum. The most testable topics involve the motor and sensory areas, as well as various nuclei whose function are related to physiology pertinent to anesthesia management in some way. So we'll focus on those. Key concept one. Working our way from the top down. The cerebral cortex is divided into four major areas. From the front to the back and wrapping around are the frontal, parietal, occipital, and temporal lobes. And the central sulcus is a groove that runs between the frontal and parietal lobes. The lateral fissure is another easily identifiable groove that runs between the temporal and frontal lobes. And both are pretty obviously recognizable in any diagram or picture. And don't be surprised if you see that on the test. The precentral gyrus in the frontal lobe control the motor function, while the postcentral gyrus in the parietal lobe are responsible for somatosensory things. The visual cortex is in the occipital lobe, and the auditory cortex is in the temporal lobe. And a couple of other tested things up here in the cortex are speech comprehension, which occurs in Wernicke's area in the auditory cortex. Makes sense that comprehension is where the auditory cortex is, while speech formation occurs in Broca's area, and that's closer to the primary motor cortex. So you'd expect formation to happen there.
Right.
Anything you want to add there?
No, I think that's great. This is really takes you back, right, to first year of med school when you had to learn all this neuroanatomy, but it does get tested. So, it is good to at least have the major stuff in your mind. No pun intended.
All right. And then some more of the important nuclei that have shown up on tests will be our key concept two. The respiratory centers, they are in the medulla. The dorsal are responsible for inspiration, and the ventral are for expiration. Just something you have to know that gets tested. B, the locus coeruleus. It's a pontine structure, and it is active during alertness and wakefulness, so it has to do with consciousness. C, the ventrolateral preoptic nucleus inhibits the wake-promoting areas and is necessary for normal sleep. And D, the hypothalamus, including specifically the preoptic area and posterior hypothalamus, are responsible for thermoregulation. So sort of a hodgepodge of things that we'll come across in anesthesia. Ready for some questions, Jed?
Let's do it.
All right. 1, reduced activity in which brainstem structure is associated with reduced consciousness? A, ventrolateral preoptic nucleus. B, locus coeruleus, or C, periaqueductal gray area.
Yeah, and again, some of this is you just have to memorize it, but I'll tell you how I remember that the locus coeruleus is involved with reduced consciousness, and that is that locus sounds like focus, and so in my mind, that's like you're focusing, you're awake, you're focused, as opposed to being more asleep, more having reduced level of consciousness and being not focused, right? So it's not perfect, but that's there. Now, you can get a little tricky because as you said, the ventrolateral preoptic nucleus inhibits wake promoting areas and is necessary for normal sleep. So if you start to think focus and sleep, you might get in there. But if you think focus as in the area that has to do with reduced consciousness, then locus coeruleus, maybe you can get to that a little better that way. As we said, the ventrolateral preoptic nucleus has to do with normal sleep, so a little different than reduced consciousness, though that's tricky. And then the periaqueductal gray area does not have to do with reduced consciousness.
Perfect. Number 2.
And Tim, let me just ask you, I mean, do you have a better way than I just described to differentiate between the ventrolateral preoptic nucleus and the locus coeruleus? Because that is a little confusing, right? Both are related to reduced consciousness, just in little different ways.
They are. I don't. I like the focus locus. I haven't heard that before. But to keep them straight, just think of what happens if you activate those areas. So activation of locus coeruleus is alertfulness and wakeness, consciousness. Activation of the ventrolateral preoptic nucleus promotes sleep. So it sort of inhibits those other.
There you go. That's what I was missing. So yes. So this is a good point because you have to pay close attention to the question stem. So it said reduced activity in which structure. So if it had said activity, that would have been maybe impossible to decide between A and B. But because it said reduced activity, that points you to the locus coeruleus, because reduced activity in the ventrolateral preoptic nucleus would actually be promoting wakefulness.
Yeah. Or inhibiting the promotion of sleep. You can run yourself ragged in circles.
Great.
All right. Somatosensory evoked potentials are being monitored by an intraoperative neurophysiology monitoring technician. The signal that is being recorded is from A, the postcentral gyrus, B, the precentral gyrus, or C, the primary motor cortex.
Great. And so, again, some of this is memorization. It's going to be the postcentral gyrus, but also if you remember, as you said earlier, that the postcentral gyrus has to do with sensation and the precentral gyrus with motor, then that helps you. This is somatosensory, so postcentral gyrus. The other thing you can use to remember this is that the if you've done anesthesia in the OR, you know that when there are neuromonitoring, the neuromonitoring folks are there, the neuromonitoring technician, they're sitting there. I think they have like their own little post. I think of it as they have a post in the OR. They're sitting there at their post. And so the post central gyrus is what they're monitoring. Now, of course, they could be monitoring motors too. So that doesn't really work for all their monitoring. But if you think of the sensation of being at their post, that post central gyrus is how they're monitoring sensation. I'm sure there's much better mnemonics for remembering that than what I just gave you. But that is one you can use.
Yeah. And then one other just test-taking tip. Sometimes you can get things right even if you don't know exactly what they're aiming at. But if you happen to remember that B, the precentral gyrus, or C are the same as C where the primary motor cortex are, those are the same answer.
Yep. And also you should be able to get rid of C at the very least because it's asking about sensory. So it's not going to be the primary motor cortex. So you could if you know nothing, you could get rid of C just by reading carefully, and then you'd have a 50-50 shot.
Perfect. Question 3. A lesion in which one of the areas can be responsible for contralateral weakness following a thromboembolic stroke? A, cerebellum, B, precentral gyrus, or C, postcentral gyrus?
So now, again, we're talking about motor. This is weakness. And so that's going to take out the postcentral gyrus, which we just talked about as having to do with sensory. And so we're now deciding between A and B. And if you remember back from neuroanatomy and neuroblock in medical school, right, the cerebellum, injuries to the cerebellum are not contralateral. They cause ipsilateral problems, often things with balance and that kind of stuff, but still can't be the answer because this says contralateral. And so that leaves you just with B, the precentral gyrus.
Great. And question 4, a mouse strain is discovered that is highly sensitive to serotonin storm syndrome. Which of the following brain areas is likely involved in the pathogenesis of serotonin storm? A, the ventrolateral preoptic nucleus, B, locus coeruleus, or C, the hypothalamic preoptic area?
Right. So here, again, I don't have a great way to know this other than you have to know it, which is that, as we've talked about, the ventrolateral preoptic nucleus has to do with sleep, the locus coeruleus with wakefulness and level of arousal, and so then that leaves the hypothalamic preoptic area as what has to be the right answer here.
Yeah, and I don't have a great way of memorizing these either. It's why there are a bunch of questions just repeating these things for us to hammer them home. The only other trick about this question is remembering that serotonin storm along with malignant hypothermia are a couple of your high temperature states that you can see in anesthesia.
Yeah, great.
Great. Next, we'll move on to the spine and spinal cord. And here there are a couple of things that are really commonly tested. Vertebral anatomy and its association to spinal nerve roots location and blood supply to the spinal cord. Key concept 3 for the vertebrae. There are 7 cervical, 12 thoracic, and 5 lumbar vertebrae. There's a sacrum, which is a fusion of 5 sacral vertebrae. And there's a small vestigial coccygeal vertebrae. A few of these are a little bit specialized. C1, or atlas, is ring-like and has no body. C2, also known as axis, has a superiorly protruding undentoid process. C7 is notable because it's the first vertebrae to not have a bifid spinous process, unlike the other cervical vertebrae, and it's the most prominent spinous process as you're palpating the back. And then the thoracic vertebrae have long inferiorly angled spinous processes compared to the relatively short, blunt, posteriorly angled lumbar spinous processes. Key concept 4, the spinal cord, extends from the level of to the level of L1 in adults and L3 in children. That'll be a test question in and of itself often.
Yep.
The anterior and posterior nerve roots at each spinal level join one another and exit through the intervertebral foramina, and they form spinal nerves C1 to S5. At the cervical level, these nerves arise above their vertebrae, but starting at T1, they exit below their vertebrae. As a result, the 8th cranial nerve, C8, is the exception coming out between C7 and T1. Notable vertebral ligaments include the ligamentum flavum, which runs along the anterior surface of the vertebral bodies, so close to the spinal cord. The interspinous ligaments are between the spinous processes, and the supraspinous ligament, which connects the tips of the spinous process, is sort of the most posterior. And our last key concept in this section, the blood supply to the spinal cord, comes from a single anterior spinal artery and paired posterior spinal arteries. The anterior spinal artery originates from the vertebral artery at the base of the skull, and it supplies the anterior 2/3 of the cord. The posterior arteries originate from the posterior inferior cerebellar arteries, and they supply the remaining 1/3 of the cord. Both anterior and posterior spinal arteries get additional flow from thoracic, intercostal, and lumbar arteries, so it's not just that superior portion that provides all of the blood flow. And the most notable of these is the relatively large artery of Adamkiewicz, or the arteria radicularis magna. It rises from the aorta, often on the left side, and is a major source of the anterior blood supply to the lower 2/3 of the anterior cord.
Great. And that comes up a lot, right, because of aortic surgery. And if you lose blood flow to the arteria radicularis magna, then that can have real risk for paralysis because of spinal cord ischemia.
Yeah, and it just lets them test it in so many ways. Do you know how the spinal cord is organized? Do you know where the blood supply comes from? Do you know which portions are supplied by what? I'm sure we'll see a question today.
Great.
Question 5. A patient has a lateral disc herniation between L2 and L3. Which spinal nerve is most likely affected?
So if they have a lateral disc herniation between L2 and L3, we want to know what nerve root is coming out above L2 and below, which is coming up above L3 and below L2. That's what we're asking?
Basically, if you have something coming out at, if a herniation is lateral between L2 and L3, what has already come out that would be impinged at that location?
Right. And so let's go back to what you said, although let's make sure we're doing this right. So the cervical nerve roots arise above their vertebrae, and then below that, they arise below it, right? So we're then saying that below L2 is the L2 nerve root, and below L3 is the L3 nerve root?
Correct.
Okay. So then...
Go ahead. No, you've got it. So here it would be AL2. And I think we have one of the things to look out for as well is whether it's a central herniation or a lateral herniation, where the lateral herniations will sort of hit the roots that have already exited and impinge on the spinal nerve roots as they're out through the foramina. And any central herniation may impinge roots that have formed in the spinal cord but haven't exited yet. So you might get symptoms in lower areas there.
Stay with us. We'll be right back. Hey there, folks. The days have been cold and snowy, and I bet, like me, you found yourself trying to stay warm, get stuff done, and with very little time to cook. Well, Factor makes healthy eating easy with fully prepared meals designed by dietitians and crafted by chefs. So eat well without the planning or cooking. 2 minutes, real food, and done. My wife and I want to give our kids healthy food that they will actually eat, but we don't have time to cook from scratch. And that's why we use Factor, and you should too. Inside your Factor box, you'll find exactly what you would have made if you had the time. Quality, functional ingredients, including lean proteins, colorful veggies, and healthy fats. No refined sugars, no artificial sweeteners, no refined seed oils. It's always fresh, never frozen. My kids think Factor tastes like restaurant food, and honestly, they're right. With 100 rotating weekly meals to keep things fresh, options like Calorie Smart, Mediterranean Diet, and GLP-1 support, and the new Muscle Pro collection to support strength and recovery, it's no wonder people love it. I wouldn't have believed it until I tried it, and now I can't get enough. Get Factor if you want all the flavor and none of the fuss. Head to factormeals.com/ACCRAC50 off and use code ACCRAC50 off to get 50% off your first Factor box plus free breakfast for 1 year. Eat like a pro this month with Factor. New subscribers only. Varies by plan. 1 free breakfast item per box for 1 year while subscription is active. Hey folks, I wanted to dive deeper into something that I think can truly make a difference for healthcare workers. FIGS scrubs. Made for awesome humans, these are scrubs that have our needs in mind. They're durable, antimicrobial, and super comfortable, which matters when you're 10 hours into your shift. I love my FIGS, and let me tell you, my wife, a pediatrician, loves hers so much that it's all she wears to work. Ever since COVID, she's all FIGS all the time. It doesn't matter if you're a dentist, a nurse practitioner, a medical student, CRNA, or CRNA student, or an anesthesiologist like me. Investing in a couple of pairs of FIGS is totally worth it. We're partnering with FIGS to get you 15% off your first purchase when you use code FIGSRX at wearfigs.com. FIGS goes beyond scrubs, too. They've got shoes, underscrubs, and even jackets that will make the ever-present hospital AC seem like a thing of the past. And they come in a wide range of colors that will let your personality shine through. Try FIGS today by going to wearfigs.com and get 15% off your first order when you enter code FIGSRX at checkout. That's FIGSRX at checkout. Hey, ACCRACers, we are thrilled to have as an all-star returning sponsor the one and only TrueLearn Smart Banks. I've used TrueLearn for my residents for years, and it is hands down the best smart bank out there. The questions are excellent, and the answers have clear explanations that break down why each choice is correct or incorrect. And now you can create flashcards, which are a key tool for high-quality studying and maximizing test performance. The education research is clear that spaced repetition with these kind of tools is the best way to learn and retain information. We use their ITE, basic and advanced smart banks for our residents, each with 1,000-plus questions, realistic visuals, and graphs, and even a calculator that mimics what you have on the exam. Our residents love it and get great results. TrueLearn even has a CME smart bank where you can get AMA, PRA, Category 1 credits after you finish training, and an adult cardiac anesthesiology smart bank as well. Go to TrueLearn.com and use code ACCRAC to get $25 off residency exams, USMLE, and Comlex smart bank subscriptions of 90 days or longer, and up to 20% off other healthcare exam subscriptions. We rely on TrueLearn for our test prep, and I recommend you do the same. TrueLearn.com and use code ACCRAC. All right, and we're back. Okay, fabulous. So, as we said, the nerve roots come out after the cervical cord below. So, the nerve root for L3 is coming out below L3. The nerve root for L2 is coming out below L2. And so, a disc herniation between L2 and L3 will get the L2 nerve root.
All right. Question 6. A 67-year-old male has undergone a thoracoabdominal aortic aneurysm repair. Shortly after the patient is brought to the ICU, they develop suspected anterior spinal artery syndrome. Which of the following symptoms would be most consistent with this presentation? A, loss of motor function in the lower extremities. B, loss of proprioception in the lower extremities. Or C, loss of vibratory senses in the lower extremities.
Yeah, so if you've seen this, you know that it's going to be motor, and usually actually it's proximal motor. So what we see is like thigh muscle weakness, leg flexion, so the ability to like bring the thigh up towards the abdomen, that gets weak usually first, and then of course it can spread from there. So it's going to be the motor function that is most consistent with this anterior spinal artery syndrome.
Yeah, and we'll talk about nociception a little bit later, and we'll get a little bit more of organization of the spinal cord. But most of the motor tracts sort of run in that anterior area, whereas the sensory tracts run in the more posterior area, which is why some of those are preserved. Yeah.
And as you said, there's only one anterior spinal artery where there's paired posterior, so you're kind of more at risk in that anterior part.
Yeah, absolutely. 7, which of the following characteristics of thoracic vertebrae make a median thoracic epidural approach more difficult than in the lumbar region? Is it A, the bifid nature of the spinous process, B, the curvature of the thoracic spine, or C, the orientation of the spinous process?
So again, this is easy once you've done your rotation in OB anesthesia, because you will have, or any, I guess, doesn't have to be OB anesthesia, but where you're doing a lot of epidurals, where you're looking at the models, and then when you, of course, do thoracic surgery and you're doing those thoracic epidurals, because it is, in fact, the orientation of the spinous processes that make it really difficult to get in a median approach. Not impossible, but very difficult in the thoracic region. You can get rid of A because the bifid spinous processes are only in the cervical region, and so that doesn't apply, and then it's not the curvature, it's the orientation of those spinous processes that is the problem.
Yeah, the curvature of the spine is actually helpful in the thoracic, whereas it can sometimes be a hindrance in the lumbar, which is why we need to get people to sort of round out their back and slouch in a way that they typically don't.
Yep, absolutely.
8, the arteria radicularis magna most often originates from the aorta in the region of A, T6 to T8, B, T9 to T12, or C, L1 to L3.
Yeah, so this is that artery of Adamkowitz, which I'm sure I'm pronouncing wrong, and that is something you just have to memorize, that it's going to be between T9 and T12. They're not going to ask you it this way, right? They're not going to say which level is it, probably, but what they might give you is a scenario where you're having a aortic graft placed between the levels of T8 and T12, and they're going to ask what your concerns are, or they may give you a different levels of where the graft might be and ask what you might be concerned about. So just knowing that general area is important. It doesn't have to be, by the way. That's just the most common.
All right. Are you ready to move on to the next section?
Let's do it.
Okay. We'll talk about the meninges next. We'll hit a few basics and then a couple of key concepts. The meninges are a protective layer around the brain and the spinal cord. They're made of 3 layers. The outermost is the dura. That's split into a periosteal layer that's close to the bone and connected to the sutures at the bone, and a meningeal layer that's closest to the brain tissue. Under the dura is the arachnoid. That's an avascular layer involved in cerebrospinal fluid metabolism, and it sort of tracks wherever the dura goes. And then the final layer is the pia, which is a fine layer that adheres directly to the brain and spinal cord. So this is the layer that will sort of follow all of the grooves of the brain, unlike the prior two. 2 more key concepts to add in. Key concept 6, because the dura is tightly attached to the cranium and sutures, epidural bleeds are restricted in these areas and therefore appear convex on imaging. Subdural hematomas are not restricted by these sutures and therefore have a concave shape. In key concept 7, the spinal subdural space is poorly demarcated potential space between the dura and the arachnoid membranes, in comparison to the epidural space, which is a well-defined potential space between the dura and the ligamentum flavum. The dural sheath covers most of the nerve roots for a small distance, even after they've exited the spinal cord. That's important when you think about blocks that may be placed, and the fact that you can risk subarachnoid infiltration of local anesthetic that way. And the dural sac also extends down to the sacral vertebrae beyond the end of the spinal cord. All right, question 9. A 24-year-old patient suffers a witnessed traumatic fall. After a brief lucid period, he loses consciousness and is brought to the emergency department. A non-contrast head CT for suspected intracranial hemorrhage would most likely reveal which of the following findings. A hypoechoic convex lesion, B, a hyperechoic concave lesion, or C, a hyperechoic convex lesion.
Right. So you got to put a variety of pieces of knowledge together here. First, hopefully you know that an acute bleed is going to appear hyperechoic on head CT, so you can get rid of hypoechoic right off the bat. And then you are going to have to remember what you said earlier, Tim, about how these spaces work. And you're also going to have to remember what this description is. So this is kind of, I remember, even before I was a doctor, I remember this kind of thinking, oh, this is the scary thing, right? The epidural hematoma where you're fine at first and then later you either are fine, then you all of a sudden start vomiting and lose consciousness or something like that, or you are fine and then this is why you don't want a kid to go to sleep right after they've been hit in the head, because then you might not know if they deteriorate, because you're afraid of that epidural hematoma. Subdural hematomas usually are slower and accumulate over time. So it's that acute injury where you are fine at first and then lose consciousness. So that's what's described here, brief lucid period. So we're talking about an acute epidural hematoma, an epidural bleed, and as you said, these are going to form convex lesions on imaging. So you're going to have C be the right answer. It's hyperechoic because it's acute blood, and it's a convex lesion because it's in the epidural space.
Yeah, that was wonderful. I think you hit all of the sort of key points that you could for what you need to answer this question correctly or other questions like it. I think the only thing that we didn't state yet is that your epidural bleeds tend to be arterial. Your subdural bleeds tend to be venous. But
great.
Now you have all the pieces to answer any version of that question. 10. Which of the following structures are likely traversed during paramedian thoracic epidural placement? A, skin, paraspinous muscle, inner spinous ligament. B, skin, paraspinous muscle, ligamentum flavum. C, skin, inner spinous ligament, inner ligamentum flavum.
Yeah. So this is important to, again, read the stem carefully. It is a paramedian, not a medial approach. And so hopefully you can just kind of think through that if you're coming from the side, you're not going between two spinous processes, and so you're not going to hit the interspinous ligament. And so you can get rid of A, and then with that you can get rid of A and C, and that gives you the right answer. And so you even if you didn't remember exactly, you should be able to figure that out. Even if you didn't know what it was, just interspinous ligament seems like it's probably in between two of them, and you're coming from the side, so you're going kind of around that. So the answer is B. You'll go through skin, of course, and then the paraspinous muscle, and then the ligamentum flavum.
Absolutely. As you do these questions, and you'll get one of these on every exam you take, pay attention to whether it's epidural or spinal. Pay attention to whether it's paramedian or median. Question 11. Which of the following structures represent the correct order in which they are traversed during median lumbar spinal anesthesia placement? A, supraspinous ligament, ligamentum flavum, dura, epidural space. B, interspinous ligament, supraspinous ligament, ligamentum flavum, dura. Or C, interspinous ligament, ligamentum flavum, dura, arachnoid matter.
Right. So as you said, read carefully. This is a spinal. Okay. So it's not an epidural. It's a spinal, and it's median in the lumbar region. Okay. So we know that now we are going to go through that interspinous ligament, and beyond that, you really have to know kind of the order. But if you think about it, if it's a spinal, the last thing you're going to go through is the arachnoid mater, right? Because you're going to get into the subarachnoid space. So actually, if you just think about that, you can get the right answer here, because that is the only one of them ends in that. But even without that, if you think about it, skin is not on here, though skin, of course, would be the first thing. And then you're going to go through the interspinous ligament, then the ligamentum flavum, then the dura, and then the arachnoid mater to get into the subarachnoid space. So C is the right answer.
It is. And B has all of the right things in it. It might be missing some like skin and the arachnoid matter, but the order is wrong. Supraspinous ligament you hit before the interspinous. That's the most posterior ligament in the spine.
Great.
All right. And lastly, we need to cover some of the autonomic nervous system. A lot of the questions on the autonomic nervous system are physiology. We'll leave those for another day, but there's a few things we should shore up in terms of anatomy. And since we're talking anatomy today, we'll do those. Key concept 8, the parasympathetic nervous system, which is entirely cholinergic as a side note, is composed of long preganglionic axons, which originate from cell bodies located in the brainstem, specifically cranial nerves 3, 7, 9, and 10, and sacral segments S2 to S4. Those axons, synapse, and ganglia near the target organ, and therefore the postganglionic fibers are short, since they're close to that target organ. Key concept 10, the sympathetic nervous system, in contrast, originates in the spinal cord between T1 to L2 or 3, and the preganglionic axons are short and synapse and ganglia close to the spinal cord, such as the sympathetic chain, which give rise to long postganglionic fibers that synapse on target organs. The sympathetic and parasympathetic nervous systems in their organization are almost mirror images of each other. The cell bodies are in different places. The pre- and postganglionic fiber lengths are opposite lengths. Key concept 11. The carotid bodies or carotid receptors increase neuronal activity in response to decreases in PaO2. They signal via cranial nerve 9, glossopharyngeal, to stimulate increased ventilatory drive. The aortic bodies also detect a decrease in PaO2, but their effect is mediated by cranial nerve 10, the vagus, and results in bradycardia, hypertension, bronchoconstriction, and steroid release from the adrenal glands. And then the carotid sinuses are baroreceptors, not chemoreceptors. They're at the base of the internal carotid arteries that signal via also the glossopharyngeal, CN, cranial nerve 9, to modulate sympathetic tone. Those three, I find, get lumped together very quickly. They're testing if you remember the difference between carotid bodies, aortic bodies, and carotid sinuses. And the last key concept for the day will be key concept 12, nociception, which is a transmission of painful stimulus from the periphery to the central nervous system, and occurs during a 3-neuron pathway you need to know. The first neuron cell body is in the dorsal root ganglion. We talked earlier about how it's sort of in the posterior portion of the spinal cord. Those lie in the vertebral foramina at each spinal level. The neuron has an axon that splits and extends from the periphery to the dorsal horn of the spinal cord. So it's kind of unique that the axon goes in 2 different directions and the cell body is in the middle. The dorsal horn axon synapses on a second-order cell. That cell's axon crosses the midline and ascends in the contralateral spinothalamic tract to the thalamus, where it synapses on a third-order neuron that projects to the postcentral gyrus. So you have a receptor in the periphery. That cell body of the axon that picks up that signal is in the dorsal root ganglion. It sends a little more axon to the spinal cord. You synapse, you cross, you go up to the thalamus, you go to the somatosensory area.
Great.
Okay. Question 12. Which of the following most accurately describes the organization of a parasympathetic nervous system? A, short preganglionic axons, long postganglionic axons. B, long preganglionic axons, long postganglionic axons. Or C, long preganglionic axons and short postganglionic axons.
Yeah, so you just went over this. I don't have a great way to remember it. If you remember the anatomy, like you said, the parasympathetic nervous system, which is what we're talking about, has synapses near the organ. So these long preganglionic axons and then short postganglionic axons because you're already near the organ. So if you remember that, then you know the answer here is C. B doesn't exist. There's no long. And then A is the sympathetic nervous system, short then long. And I guess you could try to remember sympathetic starts with short, starts with S. So short sympathetic is the first part. That might help you.
Yeah, and for what it's worth, for me, it's easier to remember the sympathetic system because I think we all remember the sympathetic chain and we know that it sits right next to the vertebral bodies. So if you know that those cell bodies originate in the spinal cord and don't go far, you know the sympathetic has a short preganglionic. And if you know that both have a long and a short portion, you can reason out everything else from there. Question 13. Soon after emergence and extubation from general anesthesia for a lower extremity orthopedic procedure, a patient becomes hypoxic. Their breathing becomes rapid, which is most likely mediated by activity of which area? A, carotid bodies, B, carotid sinuses, or C, aortic bodies.
Yeah, and this is tricky. So hopefully you can remember that the carotid sinus is a baroreceptor, so it deals with pressure, and so you can get rid of that. The carotid body is a chemoreceptor, so it does deal with things like pH, hypoxia, hypercarbia, and so you can remember that by CBC. You order a CBC, the blood test, so carotid body chemical CBC. But the tricky part is that the aortic bodies also are chemoreceptors, as you said, and so what you have to remember here is that the aortic bodies, as you went over earlier, Tim, have a different effect, which is that their effect is bradycardia, hypertension, bronchoconstriction, steroid release. And it is the carotid bodies that go through cranial nerve 9 and have increased respiratory drive. So you have to remember the carotid body is that chemoreceptor that increases respiratory drive, and that's why it's the right answer here.
Perfect. And our last question for the day. 14. Signals passing through the dorsal root ganglia most likely originate in which of the following? A, peripheral nociceptors, B, the spinothalamic tract, or C, the premotor cortex.
Great. And so signals passing through the dorsal root ganglia, where do they originate? And that's key, that word originate. Where are they starting? So you know that these are pain fibers, and so they are going to need to originate peripherally in nociceptors on their way up to the brain. So peripheral nociceptors, that's the right answer, choice A. They're not going to originate in the brain because they're traveling to the brain, right? These are the ascending pathways, and similarly, the spinal thalamic tract, they need to start somewhere peripherally and then pass through on their way up.
Perfect. And if you ever get confused in some of these tracts, remember that they're often named for the direction of travel. So the spinothalamic tract is spinal signals going to the thalamus. So it's peripheral signals going up. They wouldn't be going down to the dorsal root ganglia.
Yeah, and right, and then that is key, though, that we are talking about a somatic. We are talking about somatic signals, right? So they are going up, but they can't start in the middle. They have to start peripherally. So that's Correct. Why it's got to be the nociceptors.
Correct.
All right, fabulous. Let's turn to the part of our show where we make random recommendations. Tim, what would you recommend the audience check out for fun these days?
A board game that also has a good app on the phone called Shards of Infinity. If I remember who recommended it to me back in the days or first introduced me to it, I would. I don't remember. It's a deck building game where you don't have to buy more cards with it. You buy the one thing, but in each game you build sort of a deck that you play with, and you try to deal enough damage to beat your opponents. It is infinitely playable. There's no one good strategy. The cards that show up on the table really change how each game is played. And it's one of the games that I think I most often don't play for a little bit and have to pick right back up after a while.
Say again what it's called?
Shards of Infinity.
Nice. Sounds awesome. All right, I'm going to recommend a new game from the New York Times called Crossplay. It's basically Scrabble, but it is Scrabble, but I think they made slight changes to the board, just so that probably I'm guessing for copyright reasons, so that it wasn't exactly Scrabble. But it's essentially Scrabble, and you can play either with the computer, or you can play with a random opponent, or you can play with friends. And it's nice because you can just do it whenever you have a chance. So you take a turn, then maybe you get busy, and you come back to it a few hours later, or even the next day. You take another turn. There's no rush. And what I have found is that the app does a pretty good job of matching you up with people who are similarly skilled once it's seen you play a few games. So what I did is I played against the computer for several games, and then it kind of got a feel for my skill level and then matched me up. So the games I've played against random people have been pretty close, and that's a lot of fun. So check it out, Crossplay from the New York Times. All right, Tim, thanks so much for coming back and doing another keyword episode.
Thanks so much. And I just sent you a friend invite on Crossplay, so
it's on. Play later. It's on now. All right. Hopefully you got as much out of that as I did. That was really fantastic. Let us know what you thought. Go to the website, ACCRAC.com, where you can leave a comment. Others can learn from what you have to say. If you are a fan of the show, you can follow us. We're on Twitter. We are on Facebook. We are on Reddit. And we are on Instagram. I'm at Jay Wolpaw on Twitter, and we're at ACCRAC Podcast, and you can find us on all those other platforms as well. If you are a fan of the show, please consider going to Apple Podcasts or wherever you get your podcasts and leaving a comment and a rating. It really helps others find the show. If you'd like to support the making of the show, please consider going to patreon.com/ACCRAC. That's patreon.com/ACCRAC, where you can become a patron of the show. Even if it's just $1 or $2 that you pledge, it makes a big difference, and we really appreciate it. You can also make donations anytime by going to paypal.me/ACCRAC or looking up Jay Wolpaw on Venmo. Thank you so much to those who have already made donations and become patrons. We really appreciate it. Thanks, as always, to our fantastic ACCRAC crew. Sonia Amanat is our tech lead. Taylor Duggan, William Mao, and Rachel Furman are our production assistants and social media managers. Thanks so much for all you do. Our original ACCRAC music is by Dr. Dennis Quo. You can check out his website at studymusicproject.com. All right, that is it for today. For the ACCRAC Podcast, I'm Jed Wolpaw. Thanks for listening. Remember, what you're doing out there every day is really important and valued.